Yeah, so here in South Africa, we have been actually working on the issues of ensuring equitable distribution of health workforce. And we know that, and everybody understand also in line with the previous presentation, that geographical maldistribution of health workforce is a critical concern for health planners like myself in South Africa, and it has been for years. The inequities in the distribution of health workers across the 9 provinces and between urban and rural areas is undeniable, as indicated by the previous speakers. To address these inequities, the South African government has developed and applied several health workforce strategies. Next slide. So progress in relation to equity in health workforce distribution. What we have worked on in government, or what we've been dealing with, is development of rural and retention strategies, which some of them we have worked together with the WHO, as alluded by Retika and also Dr. Theodora. We also have foreign workforce management, which is also another unit where actually we are not just looking at managing foreign workforce, but also recruitment of foreign workforce from other countries, particularly for the areas where we don't have skills and expertise in South Africa. We have also been providing rural allowance. As you have heard, in some areas there have been challenges. However, the rural allowance also is one of the policies that has assisted us in ensuring that we are able to recruit and retain health workforce in the rural areas. Just a few years ago, almost 2 decades ago, we also introduced what we call community service, where actually the newly graduates, particularly medical doctors, the nurses and the pharmacists, they have to do community service before they can actually given a letter to conduct or to practice independently. We have also introduced policies like remunerative work outside public service, which is RWAPs. By RWAPs, actually, we are able to get those professionals who are in rural areas to do some work also in some urban areas or in actually neighboring facilities, so that they actually keep up to date with the skills that they have, in case in the areas where they are not able to practice the skills that they have acquired. Some few years ago, almost 10 years ago, we also introduced what we call OSD, which is occupation-specific dispensation, wherein actually we recognized actually the number of the years that actually the people have been serving, and also we recognized also their qualifications. So these are some of the policies that we have implemented. We also have actually what we call Nelson Mandela Fidel Castro Cuba RSA training of medical categories. With this program, actually, we have been able to send quite a number of medical students, those who were not going to get opportunity to be trained in the country, to be trained in Cuba, and actually most of them, they have acquired skills which allows them to work in rural areas. We also, some few years ago, in 2016, also we developed the primary health care normative guides and standards, wherein actually we have been able to assist the facility managers in rural areas and other areas, also to be able to quantify the number of health workers that they require, so that they are able to have the right numbers and the skills that they require for the services based on workload. And this work was also supported by the WHO. We have currently at the NDOH, or National Department of Health, reactivated the Human Resource Information System, Here we have actually ensured that we appoint a director who will be able to deal with this work so that we are able to collate and also ensure interoperability of data from different sources, that is from your regulatory bodies like your HPCSA, Nursing Council or Pharmacy Council, data from PESAL, data from your BHF, that is also where actually the people get paid through. And also we are working with other on areas of ensuring that the people who have to do community service also, we map also the data of those who will be actually still in the pipeline and those who will be coming through so that we are able to plan for them effectively. So there's quite a number of data sources that we are putting together. We are also leveraging on the role of community health workers, and I will talk to that. Let's get to the next slide.
It is on the next slide.
Yeah, sorry. I'm getting a message that my network is bad because of the load shedding. Also, we have been strengthening the issues related to task shifting, ensuring that actually the people or the categories who do task shifting, they are properly trained and they are properly supervised. And we know that by having task shifting in place, we are able to get these mid-level workers to deliver high quality care with shorter training at lower salaries, and they are most likely to work in areas where there's scarcity of health professionals, particularly in rural areas. We have also been working on ensuring that there's policy certainty around the community health workers. The discussions are ongoing to ensure that we look into the remuneration of community health workers. And because we know that community health workers, they also render a lot of services in underserved areas and also in rural areas. We have also looked into the role of clinical associates, which we also started with this program almost 15 years ago. It has not been, the numbers have not been growing as it was anticipated. Prof. Cooper can talk to that. However, then we are looking into how can we leverage on this resource to ensure that our district hospitals are properly staffed because of utilization of this category. Next slide. So we have also been working with the Department of Higher Education and Training to ensure that we revolutionize the selection and the recruitment of health professional students to overcome health workforce inequities, particularly when you look at the urban and rural areas divide, and also to look into what is happening between the public and the private sectors. Also, I think also as part of the higher education and training, we have actually as government recently introduced 2 universities, one in Kimberley in the Northern Cape and another one in Nelspruit in Mpumalanga. So this is in line in ensuring that those rural areas and those provinces where there are a lot of underserved areas, then they can actually be able to have or to grow their own pipeline. We are also leveraging on existing and new funding streams. That is also the issues of the training grants. And also we have been working a lot in partnership with other categories or partners to ensure equitable distribution of human resources, particularly your donor-funded partners like your PEPFAR, CDC, and USAID. So ideally, we have just actually approved the 2030 HRH strategy for South Africa, which sets out which sets out actually the overall goal, that is vision and actions that will advance processes of addressing persistent issues in inequity in the healthcare workforce. Next slide. So what are the additional measures that we are looking into or that are being considered? We are looking at ensuring effective health workforce planning to ensure human resources for health alignment with current and future needs, particularly now when you look at the issues of COVID-19. We have realized that there's a need actually to focus on the categories like your epidemiologists and also the surveillance professionals. We are also looking into institutionalizing data-driven and research-informed health workforce policy and planning. I've already talked that we have actually reintroduced the Directorate on HR Information System, and this will assist us in ensuring that our planning and our management and development is informed by data. We are also looking into ensuring appropriate staffing targets and norms, and to ensure that these are well defined, to ensure that we look into what are the needs currently, both in rural and urban areas, to ensure that the services are actually rendered properly. One of the issues that have been actually identified in the 2030 HRH strategy is to look into a biannual HRH Indaba. This is also something that we're considering, where we will be actually having all stakeholders, including yourselves, also to look into how do we actually re-energize our actually HR planning, management, and development issues, and also share best practice. We are also looking into reviewing lots of policies which I've not mentioned here. Our community service, there are a lot of calls on whether do we want to actually keep the number of the years or do we want to decrease the years, and also including rural allowance to harmonize this with geographical applications. Next. So in conclusion, the distribution of health professionals in South Africa is relatively equitably distributed across provincial areas, although I've already indicated that we agree that indeed rurality does have an effect, particularly when we look at hospitals' levels of care. Whereas if you look at the distribution of health workforce in primary healthcare settings, the distribution of health workforce seems to be better. However, even in primary healthcare settings, we've realized that doctor distribution or medical doctors or physicians, they appear to be more pro-urban than actually other professionals. Hence, we are talking about the issue of ensuring fair distribution of HRH across the country. And also we are looking at it thinking that data shows that this must have been caused by low application of some of the rural policies that we have in place. And this actually has been depicted by the challenges that we have seen in the past 3 decades. So hence, as government, we do have political will, as indicated by Theodora. whether is there political will. Yes, we do have political will, and we are committed to continue in reviewing our HR policies, including those that affect equitable distribution of health workforce in the national health system, to ensure that we do not have challenges in the rural areas as indicated. I thank you.